In this video, we'll explore how the optic nerve head reveals the earliest signs of glaucomatous damage and why recognizing these disc changes is vital in the management of primary open-angle glaucoma. In POAG, the core pathology is the progressive death of retinal ganglion cells and their axons. These axons converge at the optic disc, making it the primary site for detecting structural changes in early disease. One of the earliest and most consistent signs is an increased cup-to-disc ratio, especially in the vertical axis. A vertical CDR greater than 0.6 or an asymmetry of more than 0.2 between the eyes is considered suspicious. But relying on the size of the cup alone can be misleading. Larger optic discs may naturally have larger cups, and conversely, small discs with small cups may still have glaucoma. That's why it's essential to go beyond just the numbers. Notching of the neuroretinal rim is a highly suggestive early sign. In glaucoma, rim loss typically begins in the superior and inferior sectors, areas with the highest concentration of nerve fibers. This focal thinning of the rim can appear before any visual field defects. It's important to apply the ISNT rule when examining the disc. In a normal eye, the inferior rim is thicker than the superior, which is thicker than the nasal, and finally the temporal. Violation of this rule, especially with superior and inferior rim thinning, is an early indicator of glaucomatous damage. Additional clinical signs include bearing of circumlinear vessels, where blood vessels appear to hang unsupported over the edge of the cup. Bayoneting of vessels, sharp angulation where vessels dip into and out of the deepened cup, is another hallmark of structural loss. Nasalization of central retinal vessels may be seen as the neuroretinal rim thins temporally, forcing the vessels to shift toward the nasal side. As the disease progresses, you may observe the laminar dot sign. This occurs when the overlying neural tissue is lost to the extent that the pores of the lamina cribrosa become visible. In advanced cases, pallor of the optic disc may be seen. But it's important to note that in glaucoma, cupping is typically more prominent than pallor, unlike in other optic neuropathies. Don't forget to evaluate the peripapillary region. The beta zone of peripapillary atrophy, adjacent to the optic disc, is a well-established structural change in POAG. It appears as a pale atrophic area lacking pigment epithelium and is often more prominent temporally. Enlargement of this zone over time can be a marker for progression. Clinical examination begins with a slit lamp biomicroscopic evaluation of the disc using a 90D or 78D lens under dilation. Red-free illumination enhances visibility of nerve fiber layer defects. Fundus photography is essential to document baseline appearance and follow progression. Advanced imaging techniques allow objective assessment. Optical coherence tomography, or OCT, is the gold standard. It quantifies retinal nerve fiber layer, RNFL thickness, ganglion cell complex, and optic disc topography. Structural damage often precedes field loss. RNFL thinning, especially in the superotemporal and inferotemporal regions, is a sensitive early indicator. Scanning laser ophthalmoscopy, HRT, and scanning laser polarimetry, GDX, can also be used but are now largely supplemented by OCT. To summarize, glaucomatous optic neuropathy presents with a sequence of disc and peripapillary changes. Increased cupping, rim thinning, ISNT rule violation, vascular signs like bayoneting and nasalization, laminar dot appearance, disc pallor in late stages, and peripapillary atrophy. Detecting these signs early, even before parametric loss, can be sight-saving. Remember, structural changes often precede functional loss, so don't wait for the field to go dark. Thank you for watching. Subscribe for more concise, high-yield ophthalmology videos.